All right, thank you. We tested this, so we'll see if it goes. Kapow. I have nothing to disclose. I'm just here for the fun of it. All right, so sometimes I know you guys come to talks and you say, why are you qualified to speak? And so this is just a little of my background. I was in the Air Force. That's where I got my training as an X-ray and CT tech. I then, when I got out of the Air Force, I was a CT supervisor, went on to be a manager, director of a hospital, and as of October, so very fresh in my role, I'm a regional director for the St. Louis region for SSM Health. With this presentation, I'm going to take you on the journey of what we did to grow volume in this horrible imaging market we have right now, where you have literally no staff. We're all trying to recover from COVID. And one thing that's really neat is if you looked in your little folder, the book, to decide if you wanted to hear me speak. When I submitted this presentation, to be in this presentation, and I gave them kind of our elevator speech of what I would be presenting on. This number in your little book said 7.1% because it was about mid-year. I reran the numbers at the end of the year, and we actually ended the year 18.6% above prior year's volume. So that's really what I'm here, is kind of to take you on that journey, show you this makeshift program we developed from the ground up using simple lean processes. And the takeaway I hope you get from this is either say, that's kind of a cool program, we can implement it, or if you think the program is silly, at least you can see the tools I used from lean to help us engage our teams and get the results. So it's kind of twofold. You can either just mimic this all together or just kind of take the bits and pieces. But I hope you leave here today with something to kind of noodle on your trip home and say, yeah, I think we can do that and improve our department. So right now, we're in very unprecedented times. As I mentioned, I've been in healthcare for 23 years, and it ebbs and flows. I can remember 10-ish years ago, I would put a position out, and I would have so many applicants, and many of those applicants are like, I graduated school 3 years ago, I graduated 2 years ago, I've been working at PetSmart, I just want a job, I will work anything. You have midnight open, that's fine. You have midnight weekends open, that's fine. I'll take per diem. It's totally different now. And so the ASRT did some research. They started tracking in about 2003. And just from 2021 to 2023, vacancy rates are up to 18.1%. I would be shocked, raise your hands in the room. Are any of you fully staffed across the board in your departments? You might have some departments that are staffed. But it really is. And so more so after COVID, a lot of us are having issues with NOI, your net operating income. We've got to figure out how to make money. How do you buy new equipment if you're not bringing in revenue? But it's this vicious cycle of, I know, but I can't staff my departments to do the outpatients. And so it's just this vicious cycle. So we can't just sit and be stagnant and say, well, I can't hire any people, so I can't open my slots. So that's where we kind of started working on what can we do to improve. And so to further dive into what that vacancy rates, this is the vacancy rates from ASRT of 2021 is that first line, and 2023, how it ended is that last line. So CT across the board, this is across the country of all the hospitals surveyed, is up to 17.7% vacancy rates. Ultrasound, 16.7. MRI 16.2, nuke med 14.5, and even mammo. I would say in my region, I have 7 hospitals under my purview, and we have about 15 outpatient centers. Mammo for us is very steady. I was surprised to see this number because you usually don't have weekends on mammo. There's no nights calls, etc. And it feels like mammo, we're usually pretty, in my region, pretty well staffed, but mammo is even jumped up to 13.6. So when I start to talk to our leaders who aren't understanding, why are we not growing volume? Why? We're the money makers of hospitals. It's just, we have to have that outpatient volume. We're a huge revenue generator. And so if we're not able to do the outpatients, you don't have that revenue flow coming into your hospital to have capital purchases. We've been fortunate enough that I've been able to get capital. But even within this conference, when I've been talking to different people, some people are like, we haven't gotten a new piece of equipment in 2-3 years. There's just not the money. So I try to really share this with my upper leadership for them to understand. And I've really tried to change the culture within our organization of speak in vacancy rates, because a lot of the upper, your C-suite, your CET, they're used to hearing we're down 45 nurses, because when you look at how many people work in a hospital, it's primarily nurses. So when I go in and I go, I'm down 3 MRI techs. Ooh, 3 people, big whoop. Yeah, but my staff, my fully staffed department is 5 MRI techs. So I really am trying to get the culture to change and speak in vacancy rates, because me saying 3 MRI techs or me saying I'm down, I have a 72% vacancy rate, that's completely different to people that are used to hearing these large numbers like 45 nurses. So we really, I wanted our organization to see the rates. And this is the national average compared to my hospitals. Even radiology, general radiology, we have students. We have students from our local schools, but so does everyone else in our region. They have students from local schools. I met with our local community college and I asked them, you know, how many students are you guys putting out? And they say, you know, we usually graduate about 80 students a year. And they were able to provide me data with not only from SSM, but we have 2 other large systems in our area that currently posted, as of last week, there were 457 radiology positions posted. They're graduating 80 students a month or a year. Do the math. We've got to find people from somewhere. So that's where we really wanted to kind of dig into, okay, I'm not going to produce more students. I'm not going to be able to just, and I am starting a partnership with the college to try to increase how many students they can take. But still, that's going to take time for those students to graduate. So we really looked as a department to say, what can we do to close this gap? Because MRI, I don't know how you're fully staffed. I'm a really fun person. I would want to work for me, right? MRI is our worst department right now, and that's our biggest revenue generator. I mean, if you don't have your MRI departments open, it's really impacting your operating income.
Currently, I have a lot more students, and I'm having to stay at positions.
And Nuke Med, for our data here, I have PET lumped in there. Nuke Med, the actual Nuke Med departments, we are pretty stable because they're so teeny tiny. I have like 2 techs and they've been working there since, you know, before I was alive. Some of them have. But it's our PET. I can't keep a PET tech. And so that it like I said, it ebbs and flows of, as I was mentioning on the prior slide, my mammo department's pretty solid. We're pretty good in mammo. So we started kind of this program just at 1 hospital. So I mentioned that we have 7 hospitals. We have 1 hospital, St. Joseph, St. Charles, the abbreviation is SJSC. And of that 1 hospital, these are all outpatient centers that tie up to that hospital. And the reason we started this there is because I have other hospitals where it's a hospital and on the 3rd floor is our main radiology department. And then over here on the same campus is our outpatient department. This hospital is very unique because we have all these outpatient centers that are freestanding outpatient centers, have everything except for Nuke Med and IVR there. We have mammo, MRI, ultrasound, CT, plain x-ray, and they all tie up. So now when I'm talking about those vacancy rates, and you're talking about each of these locations, I have a CT tech, a CT tech, 1 MRI tech, and a tech assistant, because we can't, who can get 2 MRI techs to work together? That's really where vacancy rates really start to hurt us, because it's not like the hospital where we can kind of pull and move people around. We have what I call these little island centers that, being down 1 tech, even though globally we're 1 big department, it was really hurting us in terms of opening up our schedules. Just some of our financials of why the revenue is so important. That 1 ministry that we have there with all their outpatient centers. In 2022, our overall gross operating revenue was $117 million. So when you're talking about closing schedules, this is really going to impact, and it's a vicious cycle. We can't give raises. We can't invest back in. I work for a non-for-profit, so we can't reinvest back in if we're not making the money. So I really felt like we have a lot on our shoulders and we have to figure out how to do more. But I can't just say, hey, I need you to scan faster and I need you to work every Saturday. It's not going to work that way, because if you recall, I said there's all those positions open with my competitors. So how do we find this balance that these techs still want to work for me, but we have to figure out how to continue to grow these numbers or we're not going to be sufficient. So this is our volume, and I went back to 2019, again, just this one hospital with all of its outpatient centers. And I went back to 2019 because really, most of our goals, if you haven't done it, we want to get back to pre-COVID. You can tell right here where we shut down all our outpatient centers in 2020 because of COVID. So the outpatient volume went down. In 2019, our outpatient volume was 95,000 patients. 2022, we still haven't gotten back. We recouped, but we're still only at 94. So in 4 years, we haven't grown. You figure, you know, when you do your budgets, most CETs or whatever, they tell you, okay, we want 2% growth every year or whatnot, you know, 2-3% growth. We should have had 2% growth, 2% growth. I can't even get back to what I was pre-COVID. So again, we're not making enough money to be self-sufficient, but at the same time, our techs are going, hey, they're giving $20,000 bonuses. It's the wage wars. As soon as they find out what I'm paying, they up at $5. And then as soon as I find out what they're paying, I fight to up at $5. But in the mix of all this, we're not making any more money. So it doesn't take a mathematician to figure out at some point you're going to go broke. So this is where we really sat down with our teams, and we had to be cautious to not say, our end goal is we just got to we got to raise our NOI. We had to think of, okay, how do we change this in terms to get our teams on board, but to really think outside of the box. And one thing with my team, I'm very big with my 3 rules, and I tell my hospital president, I report up to the regional COO, and I tell them I have 3 rules. Does it harm patients? Is it going to be a patient safety issue? Is it going to be an employee safety issue? And does it break any regulatory rules? If I can truthfully answer those 3, just try it. I don't care if we've never done it before. I don't care if we've done it 20 times before. This time might be different because we're in different times, but let's just try it. And my teams know that. And so we sat down to really think about, let's do some research. Let's figure out what we need to set our goals at, and let's do what we have to do to get there. So with that platform we had, what we started noticing is every time we lost a tech, I have to staff the hospital. We have an ER, we have inpatients, we have an OR. Guess what was happening? Well, we don't have a CT tech at the hospital, so close the outpatient center, pull that tech to the hospital. Well, there goes all that revenue. And then what ended up happening is that tech's ticked off because she likes working. I mean, who doesn't want to work in outpatient? And now I'm pulling her to the hospital. So it was this vicious cycle of just, we're not making any progress and we're not keeping our staff happy. So pulling staff, we had decreased NOI. We don't have money for capital. We don't have money for market adjustments. New technology is at risk. Everyone's talking about, we got AI, we got this, and I can't get any of that. I don't have the money to invest in that. So this is really why we needed to make a change. How are we going to grow? We're in this endless cycle. I have broken equipment. I can't afford to buy the equipment. So what are we going to do? I didn't realize it wasn't going to probably play. So I'm sure everyone in this room can fill this in, but this played, and I really aged myself because when I had checked out in our hospital, huge, conference room, brought all our teams in and said, okay, guys, we're going to put pen to paper. We're going to figure this out. And there were people sitting there going, I don't know what that movie is, but thank you. I actually have the video in here, but it's not going to play sound. If you build it, that was what our motto was. If we build it, if we have these appointment slots, I know we will fill them. So how can we open more appointment slots? Put it to the team. What can we do? We have to do something. I probably messed it up when I was trying to play the video. So we came up with a program that we call now TNA, third next available. I did a lot of research on what do doctors' offices do. I met with we have a huge physician organization. I met with our physician organization. Share me your goals. What do you guys look at? Is wait times important to you? I've been to the doctors. I don't really know if it is because I wait a lot, but wait times. And really in non-imaging doctor's offices, the focus is on your third next available, because I might have an appointment open tomorrow because someone fell off the schedule, but that's not showing my true availability. Your number two doesn't. When you get out to your third next available, when is my third next available? That's a true representation of how far booked you are. So we came up with goals. There is some literature out there about what standard benchmarks are, and really you should be able to get someone in within that work week. So we said, okay, 5 days. If you call on a Monday, I should have you by Friday. We should get you there. Our initial starting was about 22 days. CT was like 26. Ultrasound was 19. We averaged it out. We started at 22 days. You called my centralized scheduling department for this hospital. I could not get you in for 22 days for an outpatient. That's not acceptable. So we agreed on, this is going to be our goal state, is this is the only thing we're tracking, our third next available. So we had to build the foundation. I met with the director at that hospital, their leadership, their manager, their supervisors, and really had to get them engaged with this of, okay, this is what we're going to do. This is going to be your wildly important goal. This is the one thing, if you went to the talk yesterday, this is your knife. This is your knife that you are focused on. Whatever you do today, you have to put forth time here. You can't let the world win. You all know that it happens. You can go to work with a list and you can spend 10, 12 hours at work with that list and you did not get anything done from it, but you better get your focus on your third next available every day. Spend time on it. I'm not going to dictate what time you spend on it, but we need to make sure we are working on it. So we made that our wig. I put on a silly wig. We'd walk around with it. We'd have presentations. We had fun with it, but we made it our wig. So what we did with Build the Foundation, we said, okay, we're going to come up with a way that I can on the fly just say, hey, our third next available is 22 days out. What can you guys give me? We kind of treated it like if you watch Storage Wars and you're bidding. So we had to build a foundation. We worked with our Epic team and our scheduling team, and we built our foundation of our schedule out 7 days a week, 7 a.m. to 9 p.m. Already built. But then we held the slots. So we build the foundation so that it's there, and then we only have the appointment slots open that we usually work. So it spent some time to kind of build it, but we want the ability to just open slots on the fly as we figure things out, that there's not all this, because what would sometimes happen prior to this work is, oh, I found an MRI tech that'll work Saturday. Okay, did you call scheduling, get the schedule open? Oh, they get the schedule open Friday. Well, those aren't going to fill in a day. So we just wasted getting this tech. It did nothing. So we learned from our mistakes and understood we have to have the schedules built. So just open them all up, open everything up, and then we're going to place holds on them. And then we need to make sure that our own team knows how and can. They have the autonomy. You don't have to ask me. You don't have to ask your manager. They have the autonomy to open those slots as needed when they find staff. I, on the other end, worked with the vice president of the hospital and said, okay, we're going to try this program, but I have to entice the staff to work a little bit extra. They're all tired. They're already working extra. So since you know there's going to be guardrails, if we say our TNA is over 5 days and someone is willing to work a little extra, even if it's an hour extra, take it. If it's, I'll come in an hour early, take it. If they'll work half a day, it doesn't have to be a full shift, because remember, we built those schedules out to be so flexible. We have levels of bonus. I think level 1 bonus is like $15 extra an hour, and I think level 2 is like $25 extra an hour. I got approval that as long as our TNA is over 5 days, anyone that picks up anything extra, they qualify for level 1. If it's more than 10 days, anyone that picks up anything extra, they qualify for level 2. So now we have a little bit of, incentive to get staff to work just a little bit more. Even an hour, I'll take an hour. I'm not going to turn my nose up to anything. So this is our TNA tracker. It's really high tech. It's in Excel and it lives on a team site. And even as the regional director, this is my wig. So sometimes when I share this with people, and I've been asked to roll this out to all the other hospitals, so I'm taking them one at a month, one each month to roll it at each hospital. Some people say to you, I can't believe you do that every Monday. This is my wig. This is my sword. I'm going to focus on this. So every Monday when I come in, I open up my schedules and I look at when's our third next available for all those outpatient departments. We're just looking at outpatient. Here, I know it's really small. This is our Kisker location, 3T MRI, 19 days. Boom, they're over our goal. They get that bright red. Our open MRI, 23 days. Our MRI at 7-Eleven, 16 days. This one, Mammo at our 7-Eleven, that's the address is 7-Eleven. I don't want you to think it's like a convenience store. You'll notice, I know it looks a little different here. The color's a little red. It's a different red. This is the level 1 bonus. This is the level 2 bonus. We wanted it at a glance. They can see exactly. They're only at 7 days. Wentzville MRI, 14 days. So I fill this out every Monday. The supervisors and managers at that location look at this every Monday and they have conversations with their team. We have a section here for gap. We have a section here for ideas, interventions. We have owners, due dates, and how many slots did you add? So the ask of them is, if you were my MRI department, I would come out and I'd say, guys, Kisker, we're at 19 days. Can anyone give me anything? Are you guys able to do anything? And you might say, you know what, my kid doesn't have soccer today or tomorrow. I can work an extra 2 hours. Awesome, extra 2 hours. So we would put over there however many slots, and you would get the extra 25 bucks an hour for those extra 2 hours. So we were just taking anything. But what would happen is if I come in here and say, what can you guys give me? And everyone's like, I absolutely can't. That's when you need to put in here, what is your gap? Why? Why can't you give me anything? So here, their gap, they have too many vacant positions. No one's picking up anything extra because we're already working extra. There's too many vacant positions. Okay, that's your gap. What are we gonna do about it? So they put in an idea. So they put on here, work with recruitment to increase bonus 10,000 for this position. Did some research, what are others? Who's owning it? Kelsey, that's the local director there. Joe Botto, that's our recruiter. When are you gonna have this done by? Next gap there was staffing. Have a 10-hour day schedule at this location for staffing to start working. Staff were working 5/8. The staff said, let's do 10 4/10s because then maybe I'll pick up an extra shift because now I can get that bonus, but then I also get off a day off. So, all right, you guys do that. So we did this all across the board. Every time you fill this out, you have two options as the leader. Tell me you were able to fill shifts, but if you can't, tell me why. Why couldn't you? And it really was engaging with the team to come to the team. It wasn't Kelsey and Trina, who's the supervisor, and Sarah, the manager. It wasn't them coming up with these ideas. These ideas were coming from the staff. These ideas were coming from the staff. We knew the bonus because I hit too fast. One of the techs came back and said, hey, I got a call from Barnes down the street and this is what they're offering. I don't really want to leave, but hey, maybe if we offer 10,000, we can steal from them. So these are all staff ideas. So the staff are giving us ideas. The leaders are owning it because it's their wig. They know they have to do this. And it just started this kind of engaged environment where the staff know that it's not just me coming and saying, I need you to work, I need you to work, I need you to work. It's, can you guys give me anything? No, I can't. Okay, what are your ideas? And then they're actually seeing us do something about those ideas. Amazing. The leaders are removing barriers. Exactly what we're here for, right? So every Monday this goes out and they fill that data. Me as the regional leader, has anyone heard of a Pareto chart? I live by these bad boys. A Pareto chart is a visual tool. My team knows it. If you have a problem, we're gonna Pareto it out and really fine tune down what is that true problem, because it helps you identify. It's not a gut feeling of, oh, I think it's this. If we knew what the problem was, we would have already fixed it, right? So we Pareto our issues, and we do this across the board with any issue staff come to us. They're used to doing Pareto charts so that we can actually have a laser focus. Instead of throwing blindfolded at a dartboard, I now can see, and I'm going to try to get that bullseye with our Pareto chart. So my wig, my promise is, remember all those gaps on that first? I, as the regional director, am Paretoing those gaps. So I am, and the way a Pareto works, if anyone doesn't know how it works, you write from the bottom up. So you have the issues here. What are the gaps? The gaps we have listed here, we have physicians available for contrast. We have some of our outpatient centers that we don't have a radiologist on site. So we can't, even if a tech said I can work Saturday, we have no one there, we can't work Saturday because the responding physician is the medical group doctor that's in that same building and they're not there on the weekends. Recruitment, staffing, specialized block slots not being used. So the breast surgeons want me to hold how many MRI? It's always freaking MRI too. The oncologist wants on the 3T. Everyone thinks everything, we have one 3T in this area. Everyone thinks everything has to be done on the 3T. Same day cancellations. We were seeing a lot of patients dropping off same day. You're not going to fill that. There's no way we can fill that. Equipment downtime. Some departments that do have outpatient and inpatient in the hospital, they had inpatient volumes, no show, scheduling mistakes, can't scan you because you weren't prepped right. Staff training, we realized was a big one because if you recall, I have all those outpatient centers. Ask me if I have the same equipment in every outpatient center. Absolutely not. We're going to work on getting there. But we have GE, Philips, Siemens, we have everything. We have whatever was cheapest because again, we're non-for-profit. We're really broke. So we had a plethora of equipment. And so now every time on that prior screen, we couldn't add a slot, they're putting their gaps. I'm now coming in and I'm Paretoing these gaps. I'm looking at what is the issue. Okay, so you can already tell here, our main two issues that I'm going to focus on is staffing and same day cancellations. We have blank Paretos all over. Anytime someone's like, hey, we need to figure out this problem, I'm like, have you Paretoed it? Because I don't want your assumption of what you think is wrong. We need to really understand what's wrong. I don't have enough hours in the day to chase your dreams of what's going to fix it. We need to know what's really going to fix the problem. So we're going to focus on staffing and same day cancellations. When I learned what the next step is, once you identify your kind of big gaps, I always thought it was silly and our staff thought it was silly the way I kept going with it, but it really helps you find the root of the problem. We got to know the 5 whys. And when I say the 5 whys, you legitimately have to get your staff to do the 5 whys. Staffing's a problem. Why? They give you an answer. We've had positions posted for 6 months. Why? The recruiters aren't doing a good job. Why? Because there's not enough applicants. Why? And you really, it sounds silly. Sometimes they will stare at you like, I don't know why, Jessica, go ask the recruiter why they suck. No, why do you think we're not getting applicants? Let's not just point the finger. Why? And so we really worked down the why, and then we figured out, okay, we think this is the root. And then once we got to that root, now I can start working on it and again, remove the barrier, because that's what we do in leadership. We remove the barriers. So we developed countermeasures. This hangs on, we have a department board that has it's got Paretos up there because we love the Pareto. This hangs there for the staff to come up and say, saved appointment slots are not being used is the gap. Specialized scans have saved spots, breast, prostates, and do not always get filled. So what are we going to do? Jessica and Sarah, they're going to work on adjusting the release times on the saved slots, combine breast and prostate slots to reduce number of saved slots. And I will work with that surgeon to explain to her, I understand your slots are important, but you're not using them. Let me show you the data to show you. I looked at a year. Out of a year, you only use your slot 32% of the time. Not saving your slot anymore. So sorry. 48 hours before that day, I'm releasing it. Anyone can have it. So you're just going to have to get used to it. But these are all those things that the staff are going, I can't do more because I have these problems. And now they see this up there and they know my manager, my director, my regional director, all these people are actually removing these barriers. So we let our countermeasures live up there. We had specialized scans that are going to the 3T. We worked with our radiologist, we worked with our lead MRI tech, and we said, make me a list of things that should never go on a 3T. We're gonna funnel those to the other one so we can open up the 3T. Staffing was a huge one. So lack of applicants. Some people might give up there. What are we going to do there? So I did a simple Google search across the state of Missouri, and we're in St. Louis. St. Louis is a hub. There's a ton of hospitals there. There's literally one school there. There's one kind of 30 minutes this way, 40 minutes this way. I just Googled X-ray schools in the state of Missouri. Do you know how many I found? And I emailed them if they had their contact. Otherwise, I sent them a packet with a letter saying, I would love to come to your school and meet your students. And then when I met the students, I said, oh, you're graduating X-ray? Have you ever wanted to do CT? Come to St. Louis. I'll pay you. I'll pay you a relocation bonus. It was just the sign-on bonus that I called a relocation bonus. They don't know the wiser, right? We've actually brought these kids up from like rural little Missouri that there's no real hospitals down there, and they just step in and learn CT. And that's filling my gap. So again, the staff are seeing, okay, we're actually doing something. I sent letters to schools, and every quarter I send a letter to all those schools, and I list out every open position I have and tell them, if you have anyone that wants it, here's my business card, have them call me. I will figure out how to get them a job. Because again, from that very first slide I showed you, in our local area, we're producing 80 students, and we have 400 and something positions open. That's not gonna fix itself. Other lack of applicants, our MRI team, they were so stuck on, we have to have 2 technologists. And my compromise with them was, I pulled the data and I showed them, yes, we would love to have 2 technologists, but these positions have sat open for 6, 7, 8, 9, 10 months. Let's instead hire tech assistants that can do the IVs, that can learn how to put them on the table. And guess what? When we're interviewing them, I'm going to tell them, would you like to be an MRI tech? Because this is going to be your stepping stone, and we're going to help get them to be an MRI tech. And so we switched those positions. This one was really awesome that an employee came up with. We have very antiquated equipment. Our scans take way too long. We identified it's an AI that can reduce our scan time 20 to 60%. So now we can get more patients done in the same amount of time. It doesn't matter we're short-staffed. So that was a great idea. At one of our mammo departments, why does the mammo tech do DEXA? Like where in the law of mammo do you have to do DEXA? I have no idea. Our mammo on that sheet that I had shown you, we had one that was 7 days out. Make the rad tech do DEXA. Get it out of there. So we worked with Epic, changed the flow and everything. That came from a mammo tech going, I have no idea why I'm doing DEXA. It has nothing to do with what I'm doing. We don't do DEXA and mammo anymore. The X-ray techs do. And that made the X-ray techs feel a little more, oh, I get to kind of learn something new. So it was a win-win for everyone. All of these ideas came from the staff. A big one is those same day cancellations. They were coming because we didn't realize, we use MyChart. It's just an app on your phone. We didn't realize MyChart was sending a notice to patients to say that your authorization hasn't been approved and is in the pending status. If they would send it to them 2 days before their exam. So patients were panicking and canceling. We have our practice in our locations is, as long as it's in a pending status, we will scan you, because we have a 97% success rate of still securing that auth as long as it's pending. If it's denied or hasn't even been initiated, but if it's in a pending status, I work with MyChart. I said, quit telling patients that, just, we don't want them to know that. And we significantly decrease those same day cancellations. But none of this would have come to light if we weren't doing the Pareto and if we weren't involving our teams to give us the ideas, because they're the frustrating ones that are sitting there going, you know, I come into a full schedule and by lunchtime, 8 MRIs have dropped off, and you're not going to get a same day add-on MRI. CT maybe, MRI you're just not going to, that slot's wasted. Another big one that we're currently working on is, why do doctors' offices have wait lists but we don't? Why don't we ask a patient, would you like to be on a wait list? And then when that same day cancellation drops off, we can get the wait list in. So we're working with Epic to develop that. We've got it all built out and it's kind of in a trial. So I'm manually doing it right now. When patients drop off, I look at who said yes to the wait list and I have to call them, but we're working on getting it automated. And again, that was a staff idea of the people that are dealing with this every day. These were just kind of the top ones that that we worked on. Developed the wait list, the MyChart updates, getting those out, AI technology. The TAs, that's still kind of going back and forth. If we haven't had any TAs recently leave, but when the last time one left, our MRI lead said, okay, can we please post an MRI position and try to get an MRI tech in there? And I'm like, you got 4 others posted. Just, we're getting a TA in here. We're not going to do that. I think the rural school partnership has been big, and I'm even expanding that outside of our state now because I'm starting to dry up on those. But the focus is, and I know, and I don't mean any disrespect to anyone that lives in a small town, but really focusing on the rural schools, because I'm in St. Louis. If I try to pull from Kansas City, I'm not going to pull from Kansas City. Kansas City is having the same problem as me. So we're really trying to focus on those rural schools that probably don't have a lot of hospitals outside when those kids graduate. So that's the biggest thing, is that we're removing the barriers for our team. We're removing their barriers, and it's gaining trust with our teams because, again, we're out there talking to them. We're having the conversation. They all know what their TNA is. They all know it so much that if we forget to updating, they're asking us, what's our TNA? And they write it on their board, and they're vested in it. And then another big thing that I really kind of changing the culture. So on the CET side and talking to your leaders, I said, you know, you really need to talk in vacancy rates. Vacancy rates is going to speak volumes. With our staff, they don't care about budgets. They don't care about numbers. They don't care about that type of stuff. So really on changing the culture with our teams, I really tried to stress with the leaders that when you're talking to your teams, don't say, hey guys, we exceeded budget 6%. Tell them, hey guys, we helped 45 more people last month find out if they have cancer, find out why they're in pain, find out, you know, if they have appendicitis, whatever. And we turn it back to, I showed them, I like movie clips, I'm a movie person. I showed them a little snippet out of Patch Adams, and I'm like, we need to be Patch. We have to be Patch. So when we're talking to our teams, we need to be Patch, because if you remember the movie Patch Adams with Robin Williams, they would say, you know, go get the patient out of room 405. He would walk up and say, oh, your name is Jessica. I'm, you know, and I'm here, and quit talking about people by their disease, that, hey, the colorectal disease in room 45. No, that's Joan in room 45. And we really need to be more personable. And that's the culture we changed in our department, is behind closed doors, when I'm speaking with my team, yes, we exceeded budget. On my director boards, when I'm putting stuff up, yes, it says percentage. But when you're out talking to your teams, that's awesome. You were able to help 6 more people yesterday because you picked up that extra shift. Not you were able to add 6 more appointments. No, you were able to help 6 more people. Thank you so much for picking up that shift. And then next time, that resonates with them of, okay, I can stay 2 hours late tomorrow to help 4 more people. And I really think it helps remove the barriers and kind of make that personal connection. So we want full engagement from everyone. Remember, this is our WIG, our wildly important goal. This is something that I'm focused on every day. Every leader is focused on every day, and they're having those conversations so that the staff, they want to, they agree, and they want to work on this every day. Pareto, I cannot stress that enough. If you guys are not using Paretos, try it out. If you want a blank copy, I can send it to you. Sometimes staff don't understand it at first, so you kind of have to work with them, but you have to act on it. When you see that line going up, you have that conversation with the staff. Okay, why is this happening? Okay, this is what I'm going to work on, and follow up with them. You have to close the loop, or they're going to quit Paretoing, because it does take time to Pareto. But we Pareto everything. We were Paretoing in the ER. Why is our CT delay so long? We were able to determine that creatinines were taking so long, so let's get a point of care device and let's just knock these out in the room real quick and you guys can scan. And the staff came up with those ideas, but we wouldn't get there without a Pareto. So that is a big thing. If you leave here and you're like, her TNA program's stupid, I don't want to do that, at least Pareto your problems to figure out what you can deep dive on and remove the barriers. So we've entered the process improvement cycle. We're not done. We still do this. We still look. Things are constantly changing. We had our TNA down really low a couple months ago, and we lost a couple staff, and it's back up again because it takes time to get a traveler in, get them trained, and then you have to get the traveler engaged in this, and they could really care less what our TNA is. They're here for 8 weeks, you know. So we're constantly working on this. It's never ending. And like I mentioned, it worked so well at this hospital. I've been asked to kind of spread it out to our other 6 hospitals. So all hands on deck, results are seen. And I'm gonna show you some data of some secondary results that were seen that I was not expecting and I was super proud of when I saw them. So in terms of budget, we use SMART goals. I hope you guys do too. Our goal for 2023 was to improve achieving volume budgets from 98.4%. So in 2022, I ended the year to date, just shy of making budget, 98.4% to 100%. We ended the year 9% above budget. The green line is our goal. The blue line is our total outpatient volume for all those locations rolled up. The entire year, we were just knocking it out of the park on budget with those vacancy rates I showed you, with MRI departments that are 30% vacant, CT departments, all just with, I'm a baseball fan. We don't need a home run. Singles can win a game. And that's the way I look at this is I don't need you to pick up every Saturday, but if you can work an extra 2 hours on Tuesday and he can work an extra 1 hour, that's what really helped us achieve this. And it really allowed us to exceed our goal. So 9% over budget, but even better than that, because we weren't being aggressive with our budget. 9% over budget sounds good, but I think our budget from 2022 to 2023, I think we only budgeted like 1% growth because of how we were going. So woo, 9% over budget. This is the one that's awesome. Remember that year over year? That top line is 2023. We have rebounded from COVID and we finished the year 18.6% above prior year. So, and again, with less staff, just by engaging and having those conversations to say, how can we open up more slots? Not, I need you to work more, but give me ideas on how. And so in 2019, again, we were at 95,000 patients. We finished 2023 at 112,587 patients. So, I mean, 20,000 more, remember, not 20,000 patients above, 20,000 more patients we helped. And we would share this every month. We would tell them, we wouldn't share this graph. We would verbally in department meetings. We have a newsletter. We have a hospital newsletter. I really gained momentum and I wanted the hospital president to go out and bring a platter of cookies to that outpatient center and say, you guys, you helped, 500 patients get an answer to their problem. And we really changed kind of the culture of how we discuss our volumes and our growths in the terms of saved lives, individual lives. This is the one that I wasn't expecting. I got my employee engagement scores and we shot up for all of my teams that roll under me. We shot up a significant percent and we're 12 points above what the like hospitals for mine across the country are. And I wasn't even focused on this. This was just from involving the staff. It was from not having a top-down approach and really being vulnerable and coming to the staff and saying, okay, this is our problem. I know I'm your leader, but I don't know how to fix it. What can we do to get there? And we weren't expecting this, but even our employee engagement scores spiked from this. So we're really excited. We're spreading it. And I just really thought it was cool because it's not like some AHA program that you can read. We just made it up ourselves, but the data shows it works. And so we're looking to spread it, and why not share it to everyone else if you can take little bits and pieces of this to spread through your departments. 'Tis the end of my presentation.